give my virtual welcome and to say what my role is, which is to facilitate a discussion between two leading clinicians, both of whom have got the expertise, the imagination, the compassion, and the foresight to peer into the uncertainties of the future. And then we're going to broaden it out to those of you who have questions and comments that you may wish to put. Our plan is to explore some central themes that have been brought particularly into focus in this COVID year with its associated trials and its tribulations. A few salient facts just to set us up about heart disease, circulatory diseases and lung disease. There are almost 7.5 million people in the United Kingdom living with heart and circulatory diseases. 44,000 people under the age of 75 die from these diseases each year. Every 5 minutes, someone is admitted to hospital with heart disease. Some 10,000 people are newly diagnosed with a lung disease each week. Someone dies from lung disease every 5 minutes. And so those statistics go on. They're all very sobering. But we're talking not about statistics, but about people who need treatment and care, often for very many years. And it's their awareness of that that distinguishes our two guests. Professor Martin Cowie, show him, and Dr. Shelley Rahman-Haley have CVs longer than my arm, which is relatively long. So I will fail to do them justice in the couple of minutes I'm given. Martin Cowie is Professor of Cardiology and Chair of Cardiology at the National Heart and Lung Institute at Imperial College, London. His research focuses greatly on health technology assessment and the delivery of efficient and effective care for patients with heart failure, especially in relation to diagnostics, drugs, and devices. Dr. Shelley Rahman-Haley is a consultant cardiologist who specializes in echocardiology, valve disease, and mechanical circulatory support. She's currently working at the Royal Brompton and Harefield NHS Foundation Trust on the Harefield site. As I said, Martin's on the Brompton site. Just before we start, for too long, your questions, please send them using the private chat function to Ashley Westpfel. He'll collate them, and then Shelley and Martin can respond to them. So just keep them coming in as you feel the need or urge to ask something or say something, and we will come to you in due course. I want to start with both, if I may, Shelley and Martin, with you. The effect of this year of COVID-19, what's it meant for you, either personally and professionally, in your ways in which you approach your work? Let's start, Shelley, with you first.
Oh, goodness, I was going to say Martin after you. Right. Look, the first thing that I want to say, bearing in mind that we have a large audience here, is that I'm well aware that there may be people here today who have suffered losses, personal losses and great grief over the last year. And for that, for any of you, I really am truly sorry. And I want to say that because it can seem perhaps in some ways a little insensitive for us in healthcare to talk about the great challenges that we've faced over the past year. And I, in particular, as a diagnostic cardiologist, what floats my boat is working out a problem. And for me, the thing that I spent most of my time doing during the first wave of the pandemic was coordinating what was called the Cardiac Hub. As many of you may know, cardiac surgery in London was closed down completely. This was because for the majority of centres, all of the intensive care beds had to be taken up with and given over to care of patients with COVID-19. So cardiac surgery was closed down. It was also recognised very early on that if you were unlucky enough to catch COVID whilst you were in hospital for cardiac surgery, the chances of you dying was around 50%, about half and half. And so that was another reason why surgeons were very reluctant to continue normal cardiac surgical services. Harefield was designated as one of London's 2 continuing cardiac surgical hubs, along with St Bart's in the east. And our job was to prioritise clinically and arrange for the surgery of as many people from across London and the south east as we could. And I was the co-chair of the the committee, the group of doctors who were actually organising this. And every day we spent most of every single morning in virtual digital meetings like this with colleagues across the whole of the southeast of England. In fact, even the southwest, from as far away as Devon and we had Devon, Exeter, Plymouth. We had patients, Southampton, sent up to Harefield for emergency cardiac surgery who were not able to have it done safely where they were. And we also had to prioritise surgery for all the people who had been happily waiting for their operations, only to find that the waiting lists were all shut down and their operations were cancelled. So that was the thing for me, was working out the logistics of that. And I have to admit, being fortunate enough not to have lost anyone close to me through COVID, I actually really got stuck into the excitement and the challenge of trying to work out how to do this well.
Shelley, there's been a lot of discussion about whether or not, as a consequence of priority given to the pandemic, those who should have had treatment not only suffered as a consequence, but that maybe there was a disproportionate focus on COVID. The overwhelming argument, however, was that you had to tackle COVID first for all sorts of practical NHS reasons. Just briefly, what was your own view, is your own view?
There is no doubt about that. So the figures show that there were thousands of people across the UK who either did not present to acute medical services because they were frightened, or who presented late. So we saw a great increase in major complications from heart attacks because people did not dare to go to hospital until they'd been ill for many days and that sort of thing. My own interest, as you know, Jonathan, I also run a clinic and have done for more than a decade for people who have cancer and heart problems. And without doubt, the people who I think are going to suffer in the medium to long term are people who have been waiting for cancer treatment over the past year. And there is no doubt at all that that's. But
in terms of the priorities that were made, given that very difficult fact that you've stated, has it been right to have that priority, i.e. COVID comes first?
Well, it isn't what we were doing here. So we were not doing COVID comes first. We were doing prioritise the most ill cardiac surgical people and get them through in order to try and prevent people who were likely to die without heart operations from dying. Was it the right thing to do elsewhere? I don't think people had the luxury to decide if it was the right thing or not. I think it just had to be done.
What did it mean for you, Martin, this year of COVID?
Yes, well, it's been a dark year for most people, hasn't it? It completely disrupted society and the way we live our lives. So it's against that background that we think, how can we actually achieve the things we need to achieve? And overnight, instead of the old model of people seeing their doctor and having a discussion and diagnosis and discussion of treatment, we were then suddenly told we could not see patients face to face. Now, that's very disruptive for both physicians as well as the patients. I think in the first wave, to your point, we were making it up as we went along. Everybody across the world was. We'd never seen this virus before. So one can't really blame the decision-making when we saw so many intensive care unit beds and such a horrific mortality. So what can you do? It's like a war starting. You just have to cope as best you can. I think we're through that situation. We're now in that space where we have to make sure that everybody gain something from their healthcare. I was fortunate in that for 20 years I'd been interested in remote monitoring and remote consultation, but it was a little bit like a voice in the wilderness. People saying, oh, it sounds fine, but I don't really see the point of it. We have patients face to face. So thankfully, overnight, when we couldn't see people face to face, we already had quite a lot of technologies in place to help support people living at home and often very isolated with their chronic health problems. So it was slightly different from Shelley, who was very focused on how can we make sure something cardiac and operations take place across the south of England. Mine was more about how do we maintain the kind of interaction with people living with chronic conditions? How can we advise them, even though we can't see them face to face?
And Martin, as that was new for lots of those patients, although it was something you envisaged.
Yeah.
How did you find it? Did it work or did it vary between different kinds of people?
Well, I think in that crisis mode, everybody, being the old British spirit, said, well, let's just make the best of this and get going with it. So to be honest, I think most people accepted what had to happen. A lot of the technology is about video consultation. A lot of people find that quite challenging, actually getting it to work. Even tonight on the Zoom call, it's quite challenging to get everything to work. So
it's got nothing to do with the older generation, Jonathan.
Thank you very much.
But, sometimes just a telephone call is sufficient, provided you have the right information and you have the right skills to do that. And of course, we could talk about it more, but there's a lot of higher tech solutions, a lot of low tech solutions. And sometimes you do need to see somebody face to face. It's very difficult to examine somebody over the telephone, for example. Sometimes you need to do it. But it's a great opportunity to ask ourselves, what are we trying to achieve with healthcare? Does it have to be done in the old way? With all these changes, can we keep the good, get rid of the bad, and really move forward in a modern way, like we are redesigning for it? So there are some upsides to all of this, frothing around with this crisis.
Okay, let us assume that the combination of testing and vaccines mean that we do begin to get back to something like normal in the early spring, maybe a bit before, maybe a bit later. And you now have the experience of this year to use effectively. Give us a glimpse, Martin, of how you see the future. We're looking 5, 10, 15 years out, which, you could be wrong, you could be right, depends on so many other factors. But what's your imagination tell you of what is possible and should be done?
Well, I think the basic principle is, if you are somebody living with a chronic heart problem, how can you get the right advice at the right time so the right thing is done for you at that right time, and convenient for you, so that you don't have to spend hours traveling, hours sitting in a waiting room just to have a very short interaction. And I think what we're going to have is a menu of things that we can do. Some of that will just be, remote consultation. Some of it will be discussion. The GP and the specialist and the person living with the condition and their family can all be on the same call at the same time, or we can pull in other specialists to that. Sometimes it will have to be face-to-face, but it will be decided based on what's best, rather than saying, this is the outpatient department, this is the inpatient department, these are the only two ways we can cope with a problem. It'll be a much wider menu or repertoire of what we can deliver. Now, it will still have the patient-doctor relationship as central to that, but we'll use technology more sensibly so that actually it should be more convenient and hopefully better experience and hopefully better outcome. But that's what I hope for myself and for my children and grandchild, that would be the model rather than the old NHS model, which is all bricks and mortar and very inconvenient for most people nowadays.
Shelley.
So I was very interested. I mean, Martin and I have not colluded beforehand, but he said something which I have been saying through the whole of this pandemic, which is my 3 R's of modern healthcare, what we should be aiming to do, and that is to get the right treatment to the right patient at the right time. And it is very, very unlikely, looking forward a decade, 15 years, that we will, well, you talked about next year and you said things will return to normal, the idea that, in my mind, that sounds like we might go backwards to what we had before this. And certainly as far as the NHS and the delivery of healthcare is concerned, I think that's actually the very last thing that we need to do right now, because in the last 10 months, the NHS has moved forward in the way that we're able to deliver advice and care to people in ways that some of us have been trying to do for 1 or 2 decades. And just because we had to. So necessity meant that we had to move forward very quickly. And there are so many.
Why was it so difficult to do it in a way that, okay, we now see it does work? How those situations won't be restored, that people say, actually, I want it the old way. That's how I like it.
So, I mean, I think as Martin said, we're now in a position to be able to deliver care with hybrid models. So there will be people that will find that what feels right and works best for them is to come up to the surgery or the hospital and to see someone face to face. But in my experience, and of course n equals 1, but what I've found over the last 10 months is that many people who were very wary of the idea of a telephone consultation, let alone a video consultation, have actually been extremely happy with the advice and the conversation that they've had. So what this has done, this situation, is it's forced people into a situation that they wouldn't have chosen, and a significant proportion of those people have actually found that that's okay. You know, I mean, even I, as a mother, have had a number of telephone consultations over the last 10 months with general practitioners and hospital doctors about my children. And obviously I have the advantage of being medical. So I know what to say and I know what questions to ask. But even so, I have been really very pleased with the efficiency and the fact that I've been able to have the conversation from my desk here at work rather than taking the morning off. And as Martin said, if you're a patient who's coming up to the clinic and you're trying to work out when can you come when your daughter can bring you? Your son has to take the afternoon off work. Well, now they don't, because you can all join in with the consultation without all having to come to the hospital.
You're nodding away, Martin.
Yes, I agree. And I think if you think about the Brompton and Harefield Trust, it's a very specialised trust with a huge number of very skilled people that can bring great benefit to people with complex problems. And we have the most innovative solutions. But the problem is that we're only in one physical site. If you look at the old model, people had to come to us. The new model says, yes, you can come to us if that's appropriate of what you want, but actually we could have a global reach. There is no reason, in theory, why somebody with complex heart or lung problems can't actually have a video call with us. We can look at the information tests done elsewhere. We can put it together and come up with a plan. So I think in terms of the future, you asked us, for organizations, they need to rise to the challenge of saying, how can we get our expertise to the people that would benefit from it, rather than the other way around?
Martin, we've discovered home testing kits in relation to COVID, huge technological advances, AI, robotics, all sorts of things happening in many fields. How does that, in your view, impact on what you've just been talking about?
Well, I like to use the term digital support. You often hear the word disruption or transformation, and that immediately puts everybody on the back foot and thinking of reasons to say no. I like to call it digital support. And this is taking diagnostics and other tests to the individual. So as you said, home blood testing, but home monitoring is now possible for your heart rhythm and ECG, for your blood pressure, for your blood sugar, for lots and lots of different measurements. And actually, if the doctor and the team know these results, or even machine learning could sift through it so the doctor's not bothered every day with the results, machine learning makes sense of it, learns a pattern for you as an individual living at home with your chronic problems. And then when it detects that something's going in the wrong direction, before you even notice it, the theory is that it would then send a flag, which then the heart team or whatever could look at, phone you up, go through things, make sure you're not missing anything, make sure you're taking your tablets, making sure there's not a new problem. And hopefully that kind of proactive care, informed by all the data, is better than waiting for you to deteriorate to the extent that you're in a panic, you can't get hold of anybody, and you have to phone an ambulance and end up in a strange emergency room. So the
Martin,
potential for change is great.
That makes I suggest a number of assumptions about people's rationality and the way in which they behave once they are aware that they have a problem. There are also, aren't there, perhaps you want to pick up on this, I don't know, there's the psychological impact of being tested in this way with a serious long-term disease. How does one reconcile the technological potential with the psychological
it's a
impact?
Great question. It's a great question. And
I'll
jump in first and then Shelley.
Go. I'm enjoying it.
So It's about human factors. The technology is never the first and central thing. It's about the human factors. How can we support somebody with a chronic problem to live the best possible life they can in their own home for as long as possible, and only interact with healthcare system, which is clunky and expensive, when they need to. It's about the just-in-time issue. Now, I've offered remote monitoring to patients in a variety of studies over the last 20 years. Brompton's been right at the center of this technology for many years. And some people say, absolutely not. I don't want to be reminded about my condition. I just try and ignore it. That's absolutely fine. On the other hand, the majority of people, irrespective of age or background, say, yes, it's reassuring to think that actually somebody is monitoring my condition and picking up problems. Maybe I'll pick it up myself, and I would like to discuss it with you as soon as I can. Or maybe if the monitoring picks it up, then I like to do it. Think about somebody living with type 1 diabetes, a young person with type 1 diabetes. They would never expect to have to consult with a doctor before they change their insulin. They use their blood sugar monitoring, which is now in a patch. It's all very straightforward. And I think we're moving towards that when it's appropriate. But as we said, it's a hybrid model. We use the tools that work when they work for those that want to be involved.
Shelley, you're smiling broadly at that.
Well, no, I'm smiling at the idea. So when Martin was talking about patients thinking, well, someone is keeping an eye on me, and instantly, of course, I'm thinking Big Brother and someone in the background is keeping an eye on me. And I was listening to an interview on Radio 4 recently, and it was on the Today programme, and someone was talking about the use of energy meters to actually work out whether or not perhaps a more senior person who perhaps had early dementia or was frail was actually using energy, so turning on their cooker or something like that in the middle of the night, or maybe not turning it on all day, so perhaps you might infer that they haven't eaten. So being able to get that data and make inferences. Now let me ask you, Jonathan, I don't know if I'm allowed to ask any questions, but have you ever had, or do you have, a pedometer, anything that monitors your step count in a day?
My 3 members of my family have them. I think that when I was walking not so very long ago, 3 years ago, I had to do 1 year after the other 50-kilometer walks to raise funds for my charity. And I then took a proper one of this. I see how fast I was walking over what actual distance I was doing. Problem with pedometers, which is why I just don't use them, is that you make your own step length. And therefore you can delude yourself that you're walking much further or more frequently than you actually are. That's my judgment. Okay,
that's a good point. However long your steps are, let's say that you do your shopping once a week, because obviously you're a very good husband and you go out and do the family shop once a week.
Come on, Shelley.
And from the information that goes into your pedometer, into the app on your smartphone, I know, because that feeds into my database somewhere at the hospital, or an app that I can access, I know roughly how long it takes you to get round Waitrose every week. Am I assuming you go to Waitrose, Jonathan? Probably not. But anyway,
just on this domestic issue, my wife takes the view about Waitrose: why spend more when you can spend less? Why spend less when you can spend more at Waitrose?
Right, but what I'm saying, let's say, so we look over 6 months and we know that you take roughly an hour to get round and do the shopping, and you're a patient who has a heart valve problem. But let's say then over the 2 months after that, I start to see that it's taking you an hour 15 minutes, an hour 30 minutes, an hour 45 minutes, that your average time to get round is going up. That could trigger something that means that I can send you an appointment and say, we need to get a heart scan because it's taking you longer to walk the same distance on average. So what I'm getting at is that there are so many ways in which people's biological data, their heart rate, their number of steps, their activity is monitored now. And we all happily do that. We all have them, the Fitbits, and loads of my family have Fitbits, and we all talk to each other on our Fitbits and do competitions. But we can use that information to actually help provide good healthcare for you.
You talk about healthcare. Let me pick up on something else, which is long-standing issue, particularly in relation to heart disease and diabetes and cancers, and so forth, which is lifestyles, diet, exercise. How At one level, there's been so much publicity about this. Again and again and again, the message is being drummed out, while parts of the media say this is Big Brother and it shouldn't be done. People have their own choices. Worked to a very significant degree with smoking. But how do you you're looking forward 10, 15 years, can you envisage ways in which that message is got across more effectively, Martin?
Well, yes, and I think part of it's public health. As the Mayor of London, much as I hate to agree with him, he wants design of buildings so that it's difficult to find the elevators. It's much easier to find the steps, more cycle lanes, building into our cities, activity as opposed to car-based transport. I think it's about society. The reason smoking's gone down is not because we've been better at educating people about the long-term health benefits. They've known that since the 60s. It was about making it difficult to smoke, making very few places that you could actually do it, removing that, and then it went down and down. I think technology has a part, of course, but what we know is it's not just technology. You need to have the social and human factors in it. So you need to, what's called gamification of the technology. So make it a game. Try and get medals for doing more activity each week. Try and get encouragement coming in saying you did well, but you could do better. Last week you did this week you're doing this. It's those human factors. It's almost like coaching, that you're using technology to support somebody who wants to go in that direction. So I think that's quite exciting. There's a lot of work in that area. And a lot of people after a heart attack and bypass, now they're getting rehabilitation remotely and digital things to support it. But remember, unless the person wants to do it and understands why and feels rewarded for doing it, they're not going to do it for very long. So human factors are always at the core of anything we want to do.
And I think that's incredibly exciting. It's so exciting because, you see, I'm a convert to prevention. Martin will be rolling his eyes, at least internally, even if not externally at the moment. But you see, when I went into cardiology because I wanted to look after incredibly sick people. I wanted to save people who were dying in the emergency room, heart attacks and whatnot and everything. And actually over the course of the years that I've been practicing, which has been, nearly 3 decades, but 14 as a consultant, I've really had a complete about turn in what I think is the most exciting thing. And I'm asked almost on a daily basis by patients, what can I do to make my outcomes better? What can I do for my heart? What can I take? Everyone wants to know, what's the magic supplement they could buy over the internet? What can I do? What can I eat? What can I take? And I say to them all, the greatest gift you can give to your heart is exercise, is moving. It absolutely, without question. And we are now able to measure things in the bloodstream that actually show. So if you take women of a certain age, and I am a woman of a certain age, 50 next birthday, and you can measure proteins in their blood which change and show that we're aging. And if you take a group of those women and you get them to do treadmill exercise every day for 6 weeks, and then you repeat the blood tests, you can measure changes in those biomarkers, we call them, that effectively show that they are getting younger. Now, I'm not talking about immortality here, but I'm talking about the fact that exercise is incredibly good for the heart and vascular system and effectively helps to keep it young for as long as possible.
Shelley, when you as you've been practicing, and Martin as well, and if you take the British Heart Foundation, which was founded around 1960-61, since then, 60 years or so, the instance of death from heart disease has been cut by 50%. Looking ahead, do you foresee that what you've been talking about so far, better diagnostics, the mixed use of interpersonal connection and relationship with the use of AI and technology in the home, plus better preventive measures. Is this a graph that's going to continue so that we get down to very low levels? Let's come in with Martin on this first.
It makes me smile because about 10 years ago, some journalists had done a projection exactly to your point about the fall in the rate of heart disease since the 70s. Half of it's medical intervention, half is actually public health measures. And they asked the heart czar at the Department of Health, what's going to happen in the next 10 years? We've projected the line, nobody will die of heart disease at all by 2020. In other words, let's take a street floor and just keep going and then we'll all be immortal by 2050. And of course, no, it slows down. So we've had tremendous progress, 50% plus reduction in the risk of dying. I'm Scottish. Most Scottish men died of heart disease in their 50s and 60s when I was at medical school. Now that's absolutely exceptional. And things have really changed, but there's still a real problem. And the problem for the future is not only will it stop slowing down, it's probably going to accelerate as we get older, as we get fatter, as there's more diabetes, all of these issues. So more people, I'm not saying they're going to die of heart disease, but more and more people will be living with heart problems at older age. So that's a problem we've got to deal with.
I actually think that it depends on what you consider to be a disease. So again, as a valve cardiologist, so with heart valves, you know, we use this phrase, valve disease. But I don't say you've got hair disease because you've got grey hair, Jonathan. You know, there are things that we expect to happen as people get older. Now,
but sorry, Shelley, the risk to my survivability is not greatly affected by what happens to my hair as opposed to what happens to my valve. But at what point do we say that something is abnormal, that it is a disease? And at what point is it degeneration? In other words, it's aging. And I think a huge amount of what's changed over the latter half of the 20th century has been to reduce premature cardiovascular degeneration. In other words, disease. So people dying earlier than they otherwise would have done because they didn't realize that if they had a particular kind of lifestyle, they were going to accelerate what would otherwise have been natural degeneration. But so far, we haven't quite got to the point where we can do very much to reverse the natural degeneration. Now, it'll be interesting when we can do that. In one of the things in the context of everything you've said so far is, of course, who you reach effectively for prevention, who you reach for information effectively to provide information. You look at the social inequalities in this country, and you can see, you'll correct me, either of you, but I think I'm right, you can see enormous disparities which are connected in some part to do with lifestyles and diet and so on, between those who are well off and those who are economically deprived. And that is going to play a major part, isn't it, therefore, in improving the life expectancy, the healthy life expectancy of people as we, generally speaking, get older. Martin?
Yes, well, Michael Marmot, of course, who you've probably interviewed, has spent his lifetime looking at this, and he's very despondent. The social gap was dropping over about 2 decades and now is increasing again. And I think COVID will probably increase it further. So it's always an issue. Those that have more have access to most things in a better way. So how do we even things out? And you're absolutely right. There's still a very strong gradient in the country for heart and stroke disease. The gradient's north to south. The gradient's also across socioeconomic status or disposable income. So it is an issue. In digital technologies, that's also an issue, because if you don't have broadband, if you don't have a computer, if you don't have a smartphone, then how are you going to access all of the extras that could happen with that? And why do we then just deliver to those that have the technology? So it's a really important issue, and it has to stay at the top of the agenda about reaching everyone, not just the wealthy.
Shelley?
Yeah, I mean, as you will know from your pre-interview briefing, I'm a trustee for a charity called Heart Valve Voice, which is a patient-physician partnership, which really exists to raise awareness of heart valve disease. Now, a very, very well-known study back in 2016 called Oxvalve screened patients in the community who were not known to have any heart valve problems. And what they found was that just over 50%, 51% of patients, whether they knew it or they didn't, had heart valve disease over the age of 65. But if you then look at a heat map showing you which areas of the country people get access to the latest treatments. So I'm sure you're well aware, Jonathan, that now you can have a heart valve replaced without actually having to have open heart surgery. You can have it put in through the leg. We do loads of those here at Harefield, and we've also got the largest number of mitral valve clip procedures now in the UK. But if you look at the heat map, it's actually quite shocking for what should be what we like to think is a very, very highly developed country, because it shows that if you live very close to one of our very largest cities, so to London, basically, but also Birmingham, possibly Manchester. But if you live in the southeast and you live around London, you are much, much more likely to get access to the specialists that deliver these treatments and to the clinics where you'll be considered for these treatments. Now, this is in the UK in the 21st century. So we still have a long way to go to get past the inequities that currently exist.
I want in a moment to bring in some of the questions which have been coming up. I want to ask you one more thing, both of you, and it's in relation to the social media on the one hand and privacy on the other, which overlap quite a lot. There's been a huge debate about privacy, access to information, insurance companies or the market wanting more and more knowledge about you, in health insurance companies being particularly prominently interested. What you've been describing is a world in which there has to be very open communication between people like yourselves and patients, all through the NHS system as well itself. How do you reconcile, if it needs reconciling, privacy with the transparency required in order to really find out how best you can help individuals? Shelley?
Martin. Oh, well, we touched on this a little bit before the meeting, didn't we, Jonathan? And the thing that I say to most people now is that I think people don't really realise how much they've already given away their privacy. We don't even think about the fact that we enter our details into the Sainsbury's website, the supermarket website, the Waitrose, the Amazon, the whatever. We do it because there's a product that we want, and so we will give them our details, our data, in order to get that thing that we want. And I think people really don't realise what a large internet footprint most people already have. And yet, if you ask someone directly, are you prepared to allow other people to access your data for health reasons, then understandably, when you point out to them what they're giving their data for, they feel very worried. And I think this is about a compromise. I think people are going to have to decide what the risk and benefit ratio is for them of allowing access to information. I mean, I think most people, and I'm sure many people on this call, will agree that there's nothing more frustrating than going to a clinic or going to a hospital visit and finding that the doctor that you're seeing in the middle of the night in A&E is unable to access the blood tests that you had done by your GP 2 weeks ago. And it seems ridiculous to people. And I understand why. But when you say to the same people, may we link your GP's details to all the hospitals in the UK via an NHS spine, people are very wary. It somehow feels to them as if they're giving away something. What I say to most people is, you don't realise you've already given it. But this is one way in which you can give away that data and get some benefits back that really
Martin,
will
how
help
crucial
you.
Sorry.
No, go on.
How crucial, Martin, is it to break through that logjam, if that's the right way of looking at it?
Yeah, well, I'm not going to talk about social media because I think that's very different. The Twitter and Instagram worlds, that's not where healthcare goes. But if we think about data and connection, then like Shelley was saying at the moment, it's quite amusing to hear this question because it's really difficult for me to get the basic of information from even people or patients very happy to share information like the GP or another hospital. So we've got absolutely a huge distance to go. But In Europe, you're probably aware, we've got some of the strictest data regulations, GDPR, that's come in 2021, early part, about transparency, about safeguards, about legislation, about best practice, about consent. It's virtually impossible to do anything with data in Europe at the moment, and we may actually be boxing ourselves into a corner, which the rest of the world is not doing. So I think it's going to be really interesting to see how it plays out. But the whole principle...
Martin, sorry, I can see the difficulty you described. How important is it to break through? What difference does it make to the ability to deliver best quality care?
Well, I think more data is always better than less. So if you come to see me with a heart problem, surely it's better that I have as much information about you as possible from a health information perspective, rather than guessing the results of tests or waiting for results to get through to me. It'd be just great to have that all in one place. And there's actually movements to have a portal, as it's called, where you are in control of your own health data. Wherever you do a test, wherever you see somebody, information is given to you, and you actually then give permission to people to access it. And I think that vision and idea is a really good one. It's your information, you then share with it whoever you want. It's really essential. I think people don't realize that actually the absence of information, people may make the wrong decisions, and you and your discussion with your doctor is not as informed as it should be. So there's a real downside to having a data silos, as we call it.
Ashley, you've got, I know, some questions. Can you fire away with your first of them, or put them all together, or however you want to present them?
To theme them, but going on to one of the questions that was discussed just now about an ageing population, a question from Sally Sargenton. It says, one of the key challenges for the NHS today is an ageing population. We have been promised an integrated whole system transformation of health and social care services. If we don't fix social care, then nothing we will do for the health service will have any major impact. Discuss.
Exactly. Very good point.
two nodding heads. Elaborate just a little bit on that thought, Shelley.
So, I pick up on Martin's phrase, silos. I mean, it's silos, isn't it? That, you know, the separation of healthcare from social care. I mean, we don't want to have a political discussion, but the fact is it's artificial and it doesn't really work. You can't separate them, because as the population ages, as all of us, I mean, never mind the population, individuals, as we get older, everything becomes very interconnected. We develop a lot more chronic conditions, and they all interact with each other, and our medications interact with each other, and all of this affects our mental health and psychological health and our ability to perform what doctors, or junior doctors rather glibly, refer to as ADLs, activities of daily living. In other words, can you dress yourself? Can you manage to make your own lunch? Can you make your cup of tea? Can you get to the loo? All of these things are very, very closely connected. And I would almost wish I could speak at greater length to the particular person that asked that question, because I think there's a long discussion to be had really about the problem that I feel has been exacerbated by trying to separate healthcare from social care, because I think which has
been, Martin, sharply brought into focus as a result of this year, of course.
I know. Yeah. The unsung heroes are people working in social care sector, you know, underpaid, hugely worked, hugely responsible jobs. And I think COVID, to your point, has really raised that issue. But recognise, Department of Health became the Department of Health and Social Care. NICE is produced in both healthcare and social care guidelines. There is an attempt. I think everybody understands that they need to be brought together. I just think they lack the political will to say social care has to be funded properly. You know, at the end of life, it will be expensive, but for most people, it's a short period. And for goodness sake, we need to look after our old folks just in the last few months of life. So huge problem outside my remit. But I think the question is absolutely right. Health and social care are the same thing.
But of course, forgive me, social care is not just about end-of-life care. Social care can be, for many families, young people. It can be a whole range of people with different kinds of problems, from mental health problems to physical ailments, etc. Exactly. Anyway, let's have our next one.
Just following on from that question from Charles, was having created huge Excel/Nightingale hospitals in Docklands that we've not made much use of during the first wave. Will we ever use it to get rid of the growing NHS waiting list for non-COVID work?
Interesting question. Should the Nightingales, could they be used for other ailments? Who would like to come in on that of you two? You both would. Let's try Shelley first.
Right. Well, I think we all recognise that the future of healthcare involves networks, and working as networks where groups of hospitals all work together. So, for example, patients do not have to belong to, they don't belong to a hospital, that hospital, you know, the North Middlesex or Barts or Harefield or anything. They're just people that have something that perhaps needs to be done. And if we're able to deliver that out of a large site, I mean, I'm reluctant to use the word factory model, but I have heard it used. And without doubt, large community sites like the Excel premises are ideally situated to provide community diagnostic testing hubs where people could go in complete safety to have diagnostic tests done, where they did not have to come to an acute hospital where was the risk of exposure to infection and that sort of thing. And so, yes, I definitely think, in fact, we're looking at this as a pan-London network, looking at ways that we can use large empty premises like the Excel to actually do large volumes of elective ambulatory diagnostic work.
Presumably they could be used more immediately or very soon, also for providing the vaccine delivery to millions of people.
Absolutely. Anything where you need to get a large volume of people through in a safe environment, in a what we call a green environment, so they're unlikely to be exposed to acutely unwell patients where there's an A&E and that sort of thing. The premises like the Excel, and we are looking at that.
Good luck with that, because the Nightingales in Docklands, have you ever tried to get to Docklands?
Well, I did. We'll have to have a conversation after this meeting on that, because I said the same thing about that. I said getting to the Excel, and the people from the East End hospitals poo-pooed me and said it's absolutely fine.
But my point is that actually I don't think vaccines are a sensible place to crowd together a massive number of people that are not immune. So I think the idea of a vaccination is more, it has to be local. And GPs are lining up to do this, and it's convenient to you where you live, and it can be done sensibly rather than this idea of football stadiums full of people being vaccinated. But you know, if people criticise the Nightingales, what was the alternative? People were worried that people would be dying in droves in the streets with no access to ventilators. Remember where we were in the first wave. So, you know, I take the point that Nightingales don't seem to have been used, but we did need a plan B. So I've got a lot of sympathy with NHS England putting the resource there just in case it was needed. Wasn't needed. Now the question is, can we use them for anything?
And what's your answer to that question?
I'm not sure they can, because, you know, these are just empty warehouses with beds in them. They don't actually have operating theatres. They don't have CT scanners. They don't have any of the equipment we need to look after people properly. And people don't know this, but at the Nightingale, I think there was about 40 patients in London Nightingale at one point, the maximum. If they developed any other medical problems, which they often did, they had to be shipped out of the Nightingale to Barts so that they could have scans and could have other things done and then shipped back again. It's not an ideal model other than for a real kind of crisis.
This is why we couldn't use it, isn't it? So we were asked, do you have patients that you'd like to send there? And we said, no, they need to be here. However, as the chair of the North London Operational Delivery Network Imaging Subcommittee, I can tell you that we are looking now at, sadly, a lot of empty retail spaces and places like that, where if we could stick a big pile of echo machines into them quickly, and, you know, we could get well people through there to have lots of surveillance scans done in pretty short order.
You could have Echoes R Us in North London.
We will bring in our next question.
We're going. Larry wants to ask a question. Larry, I think I've unmuted you, so you should be.
Well, actually, I've got two, but I will be very quick. Shelley, I thought it was quite interesting you were talking about technology and observation. What is your feeling on an Apple Watch or similar?
For telling the time or something else? for paying for things in the supermarket?
As a
Larry, explain to Shelley what the Apple Watch does.
Well, there's, Shelley might already know this, but the Apple Watch 6...
No, but I think for her benefit, or all of our benefits, yes, you should explain.
Apple Watch 6 has the ECG capability, which as a cardiac patient is quite interesting. And then my next question is for Martin, which is about the portal facility. Now, he was talking about accessibility for notes for other hospitals. Does the portal have that option? I.e., could I take it to my local hospital and say, right, these are my Brompton notes, you need to take a look at these?
Okay, let me go first quickly, and then I'll leave you to Martin.
Shelley, we won't go too fast. I'm sure you did know that the Apple Watch did have an ECG facility.
The Apple's ECG has actually been FDA approved, and I can tell you that the ability to take rapid recordings of your heart rate and rhythm, if you feel any palpitation or fluttering, with your Apple Watch, or with even, little devices you can buy for less than £100 over the internet. And I'm not saying, I know that's a lot of money for a lot of people, but still, less than £100, you can buy a little machine, you put your thumbs on it, and it records your heart rhythm, or your Apple Watch. It has speeded up our ability to diagnose palpitations incredibly over the last decade.
If you have one or another form of arrhythmia, for instance, in heart disease, yes, can it substitute for having an ECG lying on a bed and having a full ECG?
So basically, obviously, it depends what your abnormal rhythm is. But when I was a junior doctor, and certainly when Martin was a junior doctor, there were patients who would go 20 years with their palpitations and they wouldn't be diagnosed because they had never managed to be in the hospital within reach of an ECG machine when they had the fluttering. When I was a junior, I was working in Woolwich, and I was in casualty one evening, and a woman ran in. I'm not joking. She ran through the door and went, "Put the ECG on now, put it on, I've got them. We put the ECG on, and she had a narrow complex tachycardia, a supraventricular tachycardia, which clearly wasn't going to kill her because she'd had it for 2 decades. And she took it. She virtually burst into tears, grabbed me and went, "That's wonderful, that's wonderful." I said, "You can have it." And she said, "That's great. I'm fine. It's gone now. I just needed to know what it was because they've been trying to get it for years and I've been telling them there was something." So but in reality, we can pick up the difference between something that's dangerous and something that isn't. So
even with someone with a dodgy mitral valve.
What do you say? When you say that?
Well, but the most important thing is we can pick up whether you're having heart rhythm problems because there is a rhythm problem, or whether you're having a few of these extra beats that we all get from time to time, perhaps too much coffee, called ectopics, which can feel very uncomfortable and make people feel very frightened, but they're not worrying. And so if we do pick up that there is something going on, Lowry, with a dodgy mitral valve, we can say, right, there is something there. We can see that your heart rhythm is too fast. We need to put a proper monitor on you.
Martin, the second question, the portal facility that Larry asked about.
Yes, so things are developing very rapidly on this front. So, for example, in northwest London, there is a plan to have this portal where it doesn't matter which hospital or GP you went to in that part of London, all of the information would be, with your permission, uploaded to your part of on the cloud, as we call it, just on the internet, only for access, of course, for those that you give permission to. So then that information is floating around and you give access to whoever you might see. I think that's a great idea. The French have had that idea in a kind of older way 20 years ago, where people had a credit card with a chip in it, and people would just upload the information to their credit card with the chip. Wherever they went, they took their health credit card, gave it to the doctor, and they could see every piece of information. So at last, we're kind of catching up in a kind of more modern way of doing it. Not quite there yet, but certainly started.
Ashley, I don't know whether you saw it. I saw a question flashed up from Martin Armstrong.
That was going to be my last question, Jonathan, was about...
Right, okay, anyway, you fire away.
Okay, so, Martin Armstrong, which I think went out to everyone, but my daughter, age 5, has also had a number of heart surgeries. What medical improvements do children needing heart and or valve surgery have to look forward to in the near future?
Pretty pressing question. Martin Curry.
Well, Shelley's a valve expert, so I'll hand over to her very quickly. But I think there's lots of progress. As Shelley mentioned, a lot of operations can now be done without having to open people's chests, so it's much less recovery time. We learn a lot more about valve problems, a lot of technical developments, a shorter time in hospital, but also the way of deciding when operations need to be done is improved. And then, of course, as we've talked about it, the ability for that child, adolescent, hopefully then young adult, to keep in contact with the heart valve centre remotely, wherever they might live or travel, so they can make sure that they can remain in good health. So a lot of positive things to happen, much better than even 10 years ago. But Shelley, this is your area of specialty.
Yeah. Well, it is for more than one reason that you might not even know, Martin, and that is I might not be a paediatric cardiologist, just an adult valve cardiologist, but I am the mother of a child with congenital heart disease who had a very large hole in the heart closed at the age of 6. And I would like to offer reassuring words, in all sincerity, I can offer reassuring words to parents of young children with these sort of heart problems, in that, year on year, the technology for performing in less invasive procedures, so for correcting things and for re-correcting them without major invasive surgery, all these technologies are improving year on year. Our heart surgery is becoming safer and safer, and I do think that that a lot of these young children have got much brighter futures than children had who were being operated on 30 years ago.
Shelley, thank you, and actually thank you for all your questions and your comments. Wouldn't it be good if we could all be in one place sharing the conversation back and forth? Maybe for too long that will once again be possible, although it works in a way that no one had ever, most of us had never imagined a year ago. Thank you very much, Professor Martin Cowie and Shelley Rathman-Haley, for your insights and observations and your good humour. And for me, I've enjoyed it. Thank you for bearing with me, but that isn't quite all, because we're now joined by Gill Raikes. Gill.
Good evening, everyone. I'm Gill Raikes. I'm the Chief Executive of the Royal Brompton and Harefield Hospitals charity, and I did know this would be a fascinating and insightful evening. Thank you so much to Jonathan Dimbleby, to Professor Martin Cowie, and to Dr. Shelley Rathman-Haley.
On to the Brompton for a lecture.
Been very nice to hear you, and it's been an amazing journey, really, from this rather strange year of 2020 right through to many years hence for those of us who will live. I'm sure all of us will live to ripe old ages and challenge all our doctors. And Shelley, we don't call them junior doctors these days, do we? We call them doctors. But thank you very much for such an amazing journey. Could you just bear with me while I just show a 2-minute or less than 2-minute video to show what the charity is doing to support our 2 world-class hospitals right now. And I'll see you in a couple of minutes to say goodbye, but just bear with me for 2 minutes. Over to you, Ashley.
This has been a year like no other. 2020 and COVID has meant that the whole of the NHS has had to reinvent itself to be able to care for these vulnerable patients. But as we come towards the end and we're looking forward into 2021, we can start thinking again about the important work that is done here. Many of our children have cardiac problems. These are diagnosed from before they're born, most often now. And increasingly over the decades, our cardiologists have been able to bring about interventions without surgery. They can not only be life-saving, but also make sure that child has a chance of a normal life. These children are so tiny. Some of them are less than 1 kilo. And yet by going to our catheter labs, they're able to mend those babies' hearts. Immensely important work.
Patients can need multiple different procedures on their hearts, and think about young children, babies, maybe even in the first days or weeks of life, who need a complex procedure on their heart or blood vessels, and that requires the most advanced equipment that we have available. In adulthood, many procedures that used to require open heart surgery are now done in our catheter labs. This can include complex valve interventions and further investigation, treatment and long-term care for heart attacks and heart transplants. These patients continue to require procedures in our catheter lab environment and will benefit from the most advanced state-of-the-art equipment, particularly with the quality of the imaging and low radiation doses that this new equipment will bring.
The holiday season is a time to be together as a family and to enjoy your time together. Your donation for this new imaging equipment will enable more procedures for our patients, which will help them be together with their families, enjoying their quality time into the future.
Please have a wonderful festive season, and please remember that anything that you give in the first week of December will be doubled.
So even if you have the smallest donation, it will make such an impact for us. And we really, really thank you from the bottom of our hearts.
So it just remains for me to say a huge thank you to Jonathan, to Martin and to Shelley, and to thank all of you for joining us this evening. It's been really special to look into the future like this. How often do we have that chance? So thank you so much to everyone, and thank you for coming, and a special good night. Good night.